Yeah, so thank you for giving me this opportunity. I appreciate the Transverse Myelitis Association. I cannot say how grateful I am for the opportunity to have the opportunity to work with Dr. Greenberg and Dr. Graves, Dr. Froman at their clinic, and also at the Children's Hospital. And so for that, I am eternally grateful. It's an opportunity I think that not a lot of graduating residents, as they go into the next step of their training, where they call you a fellow, have that opportunity to do. So, yeah, so with drugs and cognition, I actually emailed Dr. Greenberg, and I said, Dr. Greenberg, do you want me to talk about kind of an overview of cognition, things we're concerned about TM patients, or do you want me to talk about some meds and that we use for other reasons that can impact cognition that we get concerned about? I said, did you want me to talk about medications that might augment cognition, or do you want me to kind of talk about, and then to which he just responded, yes. And so, so my main disclosure is that my fellowship is funded directly by the Transverse Myelitis Association, but I have no industry disclosures to report. So what kinds of problems are we talking about here? I have a few stories, and these very brief anecdotes are just examples. I've talked to a 15-year-old girl with a history of TM who ambulates with forearm crutches, who has a history of known chronic fatigue, who was doing fairly well, and then her grades started suffering after some problems with friends and her boyfriend. Then there was a 9-year-old girl who had a history of ADEM, who previously was an A student prior to the event, that the doctors afterwards told the parents, because she made a fairly good recovery, well, she looks so normal, but now she's getting C's and D's. And then a 17-year-old boy who is predominantly wheelchair-bound with TM, who misses 10 days of every month to school because of constant neuropathic pain and fatigue. But then there's several other adults that are battling issues at work and work responsibilities, having to tailor back work, and are also having to have issues in terms of providing for their family in addition to being a parent, because they're dealing with the sequelae of TM or ADEM or NMO. These are the kinds of things we're talking about. So if you think of it like a balance, a seesaw, when we're talking about cognition, we're talking about lots of things. Memory, short-term, long-term, attention span, just the ability to attend, whether it's watching a film or just watching a lecture for someone in school, for someone who's working, being able to participate in a work meeting. Multitasking is part of cognition. Lots of things are part of cognition. But then you have all the other stuff that ties in that a lot of patients with TM are extremely familiar with. I'm not going to talk so much about mood today, but it's a huge component. It's also possibly one of the most challenging components. I am going to talk about a little bit more about these two things and how we deal with them. And fatigue is a major issue. Pain, both chronic and acute, long-term, can be a major issue. And so these things sort of tip the scale and give you a little bit less room for these kinds of things. To give you an extreme example of how fatigue or pain or mood can impact cognition, if you talk with anybody who has known anyone, and unfortunately there are at least some of us, I'm sure, in this room, that whose parents had lost a young child, for example, you'll talk to relatives of how immediately following that event where the parent was experiencing extreme grief, just to get out of bed and manage their day-to-day activities, walking from point A to point B, was a very big challenge. That's just an example of an acute effect. And then, give you an example of pain, anybody who has had, for example, a kidney stone, while in the throes of that pain, probably could not add 2 + 5 with any degree of success. But individuals that have had TM are dealing with these things on a very chronic and in some way even more debilitating aspect. And so when you're thinking about that meeting that you have to deal with, or that child that has to do their book report and grade expectations, and while they're trying to pay attention in class, They are thinking about, if I adjust so-and-so, I really trigger that really bad burning pain in my leg. It goes on for 15 minutes. That almost makes me kind of numb all over, and I have trouble thinking. That's a big issue to have to deal with in terms of how it affects your cognition. So the issues I will cover in a brief mode: non-pharmacologic interventions to improve fatigue and how we approach that. A little bit about anti-spasticity medications and our concerns about their cognitive side effects. Anti-convulsants that we typically use for neuropathic pain and infrequently or less frequent, depending on your provider, for spasms, and our concerns about cognitive side effects, and medications that we use or have been using to actually augment cognition. So, as I mentioned, if you look at the formal definition of cognition, one of the definitions, this verbatim, was the activities of thinking, understanding, learning, and remembering. So lots of things that we're doing every day. We're doing this when you are using the bathroom this morning as you're getting ready. You're doing this when you're planning a party for your cousin. And all those things require some degree of cognition. And when you superimpose a lot of the chronic issues that patients that have had TM are dealing with, you can imagine how that's going to be very challenging. For individuals that have not had TM in the room, I'm sure that most of us can remember, and I can remember times where I had a very important interview or very important lecture or meeting, and the build up to that time period was exhausting mentally. If I had to deal with chronic pain or spasticity and had to be thinking about my walking with every step, in addition to all those things, you can imagine how exhausting that would be mentally. In children, what I focus on when I talk to families in the clinic, I think some parents think I'm kind of chit-chatting, but I'm not, although I love to chit-chat. In kids, I'm talking about school performance. I'm asking, what kinds of problems are you having in school? You know, are you having issues with the math problems, geometry? Just give me a little bit of a slice of what's going on, because sometimes that can be very telling. It cannot replace, as Dr. Harder recommends for many of our patients, those kinds of discussions cannot replace formal neuropsychological testing, but it can give us a good sense of the direction we need to go into for further evaluation. In adults, I focus on work and home management performance, and for individuals who are working, how they're dealing with their responsibilities and how they perceive the responsibilities are going, such as, well, I was usually the front runner on the major projects before I had TM. After TM, things kind of started getting scaled back, and all of a sudden I was managing the projects that are okay, but I wasn't as excited about. And those are the kinds of things we focus on. So I'm going to talk about sleep briefly. You can imagine cognition is kind of a motor moving this whole spherical setup around, and when one of these things kind of gets blown up because it's weighing you down, you're sort of just spinning in place and not going anywhere. There are many articles, documenting the effects of both chronic and acute sleep deprivation on cognition. There's actually a fair amount of research done, for example, on medical students. A lot of physicians are familiar with this, and you can chronically sleep deprive them acutely and watch their performance decrement over time. It affects various abilities, your tasks of attention, multitasking, memory retrieval, error rates in certain tasks. Effects can be reversed over time with catch-up sleep. So, okay, you're sleep deprived for 2 weeks. You spend 3 days really catching up. But if you have TM, or if you have had ADEM or NMO, and you're dealing with chronic pain that's affecting your sleep, or spasticity that really flares up at night, and you're dealing with 2 to 3 years of of impaired sleep, that catch-up effect can really take months. When we suspect that there is sleep deprivation or there's effects of other symptoms affecting sleep, chronic sleep deprivation needs to be investigated, in my opinion, in our opinion, period. What is your culprit that it's affecting your sleep? See, these are just some examples and some articles that talk about it. Is your own bladder. So getting up 3 or 4 times per night, which Dr. Greenberg alluded to yesterday at the panel discussion. Sleep is an effort that builds over time. So the later sleep in the night is of a different quality, a better quality for lack of a better term, because it's building on the sleep earlier in the night. So when you get up even to urinate and but I fall right back asleep, you are resetting that clock on how restorative the later sleep in that night is. And so that's why these are one of the, sometimes we focus on this. And Dr. Lemack focused on many medication interventions that can help reduce frequency. And there is a couple of medications we can even just give at night to reduce the likelihood of you getting up at night that might improve your sleep. Your own airway, and so a lot of people, everyone I'm sure in this room has heard of obstructive sleep apnea. One of the things I want to mention, and we're seeing this I think more and more with our adolescents, and some adults as well, is that when you're predominantly wheelchair bound, and sometimes individuals are less mobile, and the weight tends to come on gradually over time. That increased weight will put you at a higher likelihood, put you at a higher risk for having obstructive sleep apnea. And it's something that can be addressed with interventions. Some of the interventions aren't fun. A lot of people that have had BiPAP or CPAP or have tried it will tell you it's an effort in and of itself, but it can make a profound impact on the quality of your sleep. Muscle spasms, so patients that have had any kind of spinal cord injury, some of these patients have horrible muscle spasms, both the tonic ones where the muscle just locks up, or the phasic ones where their muscle is just jerking involuntarily, that really flares up at night. And when you're trying to unwind and let your mind relax as you settle down to sleep, and your mind's starting to drift off, but your leg locks up uncomfortably, that is on a pain scale of 8 out of 10, you can imagine how difficult it is to get to sleep. And then there's just life. This kind of builds into the many of the issues that our TM patients are dealing with every day, and also speaks to a lot of the mood issues that we have to deal with and work on. Work, school, interpersonal relationships are affecting each and every one of us. But sometimes when you superimpose all these things on a stressful period of your life, that can really impact your sleep, and secondarily your cognition. So I'm going to talk a little bit about some medications that we use that we have concern about their impacts on cognition over time. I will tell you that the literature for some of these medications in terms of, well, is it going to impact me or not, is lacking. And every individual is really different. These are some of the medications I'm going to talk about that are typical spasticity medications. Baclofen is a central GABA agonist, basically. GABA is one of the inhibitory neurotransmitters. So basically, we're bumping up the inhibition to dampen down the overexcitation of that's stimulating the muscles that's causing them to contract involuntarily. It's taken 2 to 3 times a day. To be honest, there are actually several animal studies that go into quite depth in terms of their concern about impact on memory and cognition over time. We know it can be sedating. Anybody who has taken baclofen, who has started baclofen, now some people say, oh, I tolerated it just fine, but there are most people, I would say, that at a certain dose or even just at a starting dose, it can be very sedating, at least even just initially. But in actuality, there's limited human data on with respect to cognition. There are a few case reports of very dramatic examples, even with intrathecal baclofen, of severe impacts on cognition, patients that have had profound baclofen toxicity. But they're just isolated case reports. There's actually a fair amount of literature looking at cognition or just degree of sedation, I should say, with baclofen because it's sometimes used for individuals that are trying to, it's been used for addiction medicine specialists for individuals that have had addictions to illicit substances. But those, and they have noted in one study in doses up to 80 milligrams per day, there was not what they call significant sedation. One of the issues that I would be interested in moving forward is really looking at school performance in a very constructive, deliberate way with structured testing in terms of how it affects our baclofen patients. I don't know with some of our patients that appear to be tolerating baclofen very well, and of course it's a risk-benefit relationship. If you derive a lot of benefit from the baclofen, then it may be worth it. But in terms of subtle school performance issues and work performance issues for our adults, the jury, I think, would still be out. There's just not a lot of data. Tizanidine, which we all know is sedating as providers, and can be very sedating, which tends to limit its use, also helps facilitate presynaptic inhibition of motor neurons. There is very limited data on tizanidine and cognition. Now, some people will tell you that take this medication, oh, it zonks me. There are a lot of individuals that have TM or spinal cord injuries that will only take it at night just because that's how sedating it is. And so that's just one other area that would have to be important for investigation. Benzodiazepines, clonazepam, lorazepam, diazepam, Klonopin, Ativan. I'm sure most of you have heard some of these medications. There is very prevalent data to impact the fact that it can be, has been shown to impact multiple areas of cognitive performance. One thing I would also caution, I'm going to diverge back into just hearkening back to sleep, is sometimes we give these and they can be quite effective just at night, and along with other sleep medications that are just used for sleep like Ambien or Zolpidem, and we give just at night to help facilitate sleep if the sleep is an issue. One thing that we don't always pay attention to is subtle changes in your morning performance. Is how are you feeling in the morning? Some people feel like, oh, I feel great, well rested, good to go. That's great. Some people are like, oh, it takes me a little bit to get going. Well, if it takes you a little bit to get going when you're at work for the first 2.5 hours, is it productive work? Are you really as efficient as you need to be? Are you really managing any of your home issues if you're predominantly at home in terms of helping your children get ready to school effectively? Or you're really requiring a lot of assistance? Again, it's a risk-benefit discussion, but it's something that sometimes we need to talk about in terms of dialing down the dose and finding that perfect combination of, yes, let's get those spasms under control at night, but let's also make sure that when you get up to go in the morning, you're ready to go. One of the medications that we've kind of become a little bit more interested in, and some providers are not as excited about this because it has a potential for some degree of toxicity to the liver, is dantrolene, which interferes with the release of calcium required for muscle activation. Again, I guess I sound like a broken record. There is limited data on dantrolene and cognition. There is the potential is thought to be minimal. I haven't talked to a lot of patients that have experienced a lot of significant fatigue. It needs to be titrated up very slowly, and blood work in terms of checking on liver function needs to be monitored closely. There is a newer study that looked at dantrolene specifically for Alzheimer's patients and found that they felt there was some effect with, some positive effect with cognition on a small scale. Botox, theoretically, should be minimal to no risk if done correctly. And one of the things that I like to bring up, at least as a trial, because all these other medications are taken orally, so they're systemic. And if you can handle getting Botox, when I say handle, getting the needles for Botox can be not fun, of course. And if you have a nice response to Botox, then in terms of its impact on your cognition and your learning or your work performance, likely would be minimal. talk a little bit about anticonvulsants and a few of them. This is not an exhaustive list of anticonvulsants that we typically use. And the reason why I'm calling them anticonvulsants and I'm not just going through them by name is every once in a while, like we get a patient we start them on something like carbamazepine or levetiracetam, or also called Keppra for spasms or neuropathic pain. And then they come back or they call 2 days later and they say, the pharmacist told me you started me on seizure medication. Why did you start me on a seizure medication? And so they all these medications were approved, initially for seizures. They act to stabilize the neural membrane, for lack of a better term, to decrease the firing rate, which may help with both spasticity or pain. It's really case by there are some studies, but in terms of what works for who is, as Dr. Froman would say, maybe a little bit of French cooking in terms of how you adjust things. They're used for neuropathic or nerve pain, phasic or tonic muscle spasms, especially at night, impacting our sleep, which secondarily is impacting our cognition, which sometimes we worry about, and then sometimes for headaches. Levetiracetam, also called Keppra. We like to use it, and there's been some papers discussing this, for phasic muscle spasms specifically that often affect patients, our TM patients at night. There are several clinical trials that show it to be neutral or beneficial with respect to cognition. Oh, that sounds great. You also got to remember that since these are predominantly approved for seizure patients, these studies are performed in seizure patients. Seizure patients, because they're seizing, have lousy cognition. So when you give them Keppra and you fix their seizures, you improve their cognition. But in general, it's thought to be neutral or beneficial with respect to, neutral with respect to cognition. I'm going to mention something that a lot of the adults don't have to deal with, and a lot of the adult neurologists don't worry about at all with Keppra, is that its behavioral effects. For whatever reason, it tends to not have behavioral effects with of adult patients. However, I would say, and the literature would say, maybe 5 to 10% of children will have behavior changes that may secondly impact school performance with Keppra. I would say it's probably in the range of 10 to 30%. And if any of the pediatric neurologists would definitely agree with me. So it's something that has to be watched for. Very rarely you will have adults that are agitated and they can't focus on things with Keppra. Gabapentin, very frequently used for neuropathic pain, not just for TM patients actually, but for lots of patients that have experienced neuropathic pain, both peripherally and that have pain secondary to TM. Also sometimes used for muscle spasms and sometimes specifically for spasticity, but I feel less so. Some providers may feel otherwise. Studies have shown limited effects on cognition. Most of these studies are head-to-head with gabapentin with other seizure medications. Again, so you have to be wary of what you're looking at. But case reports, all these seizure medications like baclofen or tizanidine can be sedating at first, and there's a getting used to kind of effect that we have to watch for. Topamax or topiramate, used for neuropathic pain sometimes. There are some TM patients and ADM patients or NMO patients that are dealing with headaches chronically that will use Topamax. There are several studies showing evidence of deficits in verbal memory, attention, and psychomotor slowing. I've had patients tell me it feels like I'm actually like when they put slow motion on the sports screen, like I'm literally thinking and moving in slow motion, and everyone else is real motion and I'm having trouble catching up. There are some people that refer to Topamax as affectionately as Dopamax. It can cause a specific subtle finding, which some patients are already dealing with when they're having to superimpose chronic fatigue or chronic pain issues, where it has you can have specifically what they call word finding difficulty. In kids that have a history of TM, for example, if they have evidence of recent language delay, or I would tend to shy away from using Topamax. Pregabalin or Lyrica is a medication that we've been using, I feel, a little bit more and more, and it can be quite effective for neuropathic pain. There is some concern that, although not to the degree or the volume of studies as much as Topamax or topiramate, that has shown, some clinical trials have shown some evidence of adverse effects on cognition on some measures. And that's another thing I'm bringing up, I'm kind of sprinkling little tidbits of things I think about as I go through this lecture, is when I say some measures. You got to remember that cognition is, as we measure it, as Dr. Harder will measure it with their neuropsychological testing, is only as good in terms of our assessment as our brief discussion with you or our measures that we're using. And we could say, oh, look, I got this, and the score's supposed to be 45, and you're at 37. And you say, oh, I don't know what that means. I think that, as we all know, and we all realize sometimes, and as some patients will find it difficult to articulate, the best evaluators of cognition are yourselves. The best exam is the exam you're talking to us about at home. When you bring in your loved ones to discuss things with us and say, John is just not functioning well, and can identify specific examples, those are the things we want to hear about, the things we work on. Because if I do some testing in clinic, well, he looks pretty good. He scores pretty good on that test. That doesn't mean nothing is going on. So then there's a physical status of patients with TM, and really I'm talking about, when I allude to this, is lots of things that can impact your energy level and secondarily cognition. Dr. Harder talked about it briefly, that new evidence may suggest cognition specifically is affected in transverse myelitis. I mentioned these two studies just kind of give us a breadth of an example, because depending on what a provider that may not be as familiar with TM may look at, they should realize that there's wide variability in the reports of fatigue in patients with spinal cord injury that can be as high as 25 to 70 or 80% in certain subsets of patients that are dealing with it. And if you're chronically tired and exhausted, and you need to be multitasking and working on school issues or work issues, that can be a major thing. What we focus on initially, and I alluded to this earlier, is this why sleep optimization is so important. If we have an issue with sleep, then you can be taking some medication like, oh, I'm moving well. My spasms are very well controlled. My pain's great. And I'm doing pretty good at school with respect to the side effects of those medications. I'm not feeling much. But if you're chronically sleep deprived, with those things doing well, and you say, well, I am exercising, then you're working against yourself, or your body is working against itself. We talk about time management skills for working in school. One of the examples that Dr. Greenberg brings up that I really, really like is, if you think about some of the ladies and gentlemen and some of yourselves in the audience, and you're thinking about getting ready in the morning, and when you think about all the steps that you take maybe from the bathroom to the closet, and it's 15 steps. 15 steps one way. Oh, I got to go get this from the bathroom. Oh, I got to go get this out of the closet. 15 steps another way. So you're going back and forth, back and forth. If you're a TM patient that has to think about every step that you take, and every step is just one more step that's going to detract from your total daily energy supply, then things like a simple thing like, well, how about this? The night before, I put out my suit or my outfit right in the bathroom, and a couple of things or options that I want to deal with. And that may be 55 steps that I've saved for that morning. And those kinds of things, when you think about them globally, and you look at your day in an incremental basis, can really add up to really benefit yourself. And of course, Dr. Greenberg alluded to this, and Dr. Pardo alluded to this, and Dr. Sadowski alluded to this, and everyone else talked about this. Exercise, exercise, exercise. And then we also have to think about, when all these things are well managed, okay, my sleep is looking really good. There's not a lot of sleep issues. And I'm paying close attention, and I am exercising. Then we have to take a step back and look back at medications, or in an sometimes acutely have to look back at maybe some illnesses that might be going on. Does someone have a urinary tract infection or some such thing? The medications that we use specifically to augment cognition, so modafinil, armodafinil, Provigil, Nuvigil, psychostimulants that tend to promote wakefulness. There are studies that have shown in MS patients, so sort of a cousin of TM, that armodafinil has been shown to enhance delayed verbal recall in a clinical trial. Modafinil shown to enhance scores across multiple cognitive tests in healthy volunteers. There are also studies with this medication across other unrelated conditions that say that it's helpful for usage for fatigue, and theoretically can secondarily impact and improve cognition across multiple other conditions. So when other things are addressed, these medications can be quite helpful. And for some patients that I've talked to, there's some people that don't respond to this, but some people that try one of these medications will call it a game changer. So the next level up, I would say, so sometimes we'll tend to use one of those medications first if cognition and fatigue are an ongoing issue, despite our best management of other factors, is the amphetamine. So it's kind of a scary word, but when I'm talking about those medications, we're talking about Vyvanse, Ritalin, Adderall, the medications that were given to 5-year-olds and 8-year-olds with fair regularity for ADHD. But when used responsibly and effectively, again, when there are TM patients or ADM patients that are dealing with cognitive issues or chronic fatigue, they can be quite effective and can be truly a game changer in terms of really enhancing your performance, facilitating you to really get done what you need to get done on a daily basis. Many studies have shown, we know it keeps people awake and can improve fatigue. Many studies show improvement with focus, keeping on task, and there are several studies showing trials with MS showing improvement in cognition. Again, I would like to say thank you to Transverse Mind Association and Sandy and his wife Pauline and everyone else that's here, and I really appreciate your support. I would like to say thank you to Dr. Greenberg and the UT Clinic. It's a wide subject, drugs and cognition. There's a lot of things that have to be thought about and addressed, but when you look at things systematically, it's something that we can work on. And so I encourage all of you to discuss with either us, if we're your doctor, or your providers, about, okay, I really need to improve my performance. We really need to take a look at things. So I encourage you to do that. Thank you very much.